The Healthcare Labyrinth podcast is back for another episode. Join Mark S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth podcast. My name's Mark Ryan. It's a pleasure to be hosting the podcast, and thanks to everyone for listening in. Today's podcast topic is going to be some of the stories I have from this year's open enrollment season and how it shows some of the really vast problems we have in our healthcare system. I am known as the healthcare guide to family and friends. For the past many years, I've had a bit of a part-time job, unpaid as it is. Given my background, I receive calls from a rather extended network of people seeking my aid and advice on the enrollment seasons in healthcare, traditional Medicare with Medicare Supplement, Medicare Advantage, Medicare Part D, Federal Employees Health Benefit Program, the exchanges, and even employer group coverage. In retirement, I plan to expand this free service for a variety of reasons, all of which I have learned from the past decade working with a number of different people each year. First, there's the stress of it all. When that open enrollment letter or annual notice of change drops, I start to get the calls. You can hear the stress in people's voices immediately. It's also a big financial decision. Depending on the health and life events, the choice to go lean or go with the richer plan can have huge implications. There's also the sheer complexity and confusion. This year, I served about a dozen folks. For some people, it takes just 15 to 20 minutes on the phone to recommend strategies, offer advice, or very importantly, to just give them confidence that they have made the right decision. In others, I have invested hours and sometimes tens of hours with each of these individuals to help them make the right decision given unfortunate life experiences they are going through. There's also so many planned terminations and cutbacks in healthcare. This year, we saw a large number of planned terminations in MA, in the standalone Part D PDP program, and even in the Federal Employees Health Benefit Program. This added to the stress of folks. These terminations are likely to continue into 2026 and beyond. So here are some of this and last year's cases in hopes that some of them resonate, sometimes unfortunately, with your friends and family. And you can offer some advice as well if you get these calls, as some of you may very well. In the end, we are all a big community supporting each other in a very complex world of healthcare. So here are some of those cases I dealt with this year and last. And we're going to take our normal breaks, so we break it up a little bit here. This could be a little bit of a lengthy podcast here today, but let's get started. And I have about 7 use cases or cases that I worked with people on this year. So let's look at our first case here. I was helping an elderly couple. One is in their mid to late 80s, and the other is in their early 90s. They have some healthcare complexity, and interestingly, both of them have clinical backgrounds. In this case, the female has Alzheimer's and a mass in her uterus. The male is a federal retiree with Federal Employee Health Benefit coverage, who overall is in good health with some mild dementia, but has increasing complexity. The female is on an MA HMO plan right now. The family and I decided to maintain the female on her existing MA HMO plan. Some consideration was made to move her to a PPO plan, but all of her doctors appear in network. She could very well hit her maximum out-of-pocket costs in 25 due to her conditions. She lives in New York, where a guaranteed issue would allow her to jump back to traditional fee-for-service Medicare and gain Medicare Supplement without unfavorable rates. But given the complexity of her husband's enrollment season, we decided to leave her where she is for now. We ran out of time to do the full financial analysis on fee-for-service and supplement costs versus MA that gives her some moot protection. The male had to change federal employee health benefit retiree plans because his local HMO plan was being terminated. Coincidentally, the FEHBP HMO plan he is on right now and his wife's MA HMO plan are in fact from the same company, but they are staying in MA but pulling out of FEHBP. That company has a very good reputation, and that is one of the reasons we felt comfortable leaving his wife on the MA plan. It was previously founded by a doctor and tends to have very consumer-friendly policies. We ended up moving the male to a Blue Cross and Blue Shield plan from his terminated plan that looks and feels a lot like a PPO. It has a wide preferred network and out-of-network access. We decided to pay a little more each month, $130 or so more, for a PPO option as opposed to some tighter HMO options, given his current payments and due to some uncertainty as to doctors that will be needed in the future. I would note that the FEHBP employee and retire plans are not particularly generous as one might think. Note, some federal retirees are not required to enroll in Medicare. The overall cost with cost sharing could exceed what it would cost to enroll in MA or traditional Medicare and supplement, even paying the monthly Part B premium for this individual. But again, time ran out. We had to make sure he chose an FEHBP plan because his other was being terminated and he was not yet enrolled in Part B. In 2025, at some point, we may end up looking to get a special enrollment period in Medicare, sign him up for Part B, and transition him to Medicare, either Medicare Advantage or Medicare Fee-for-Service with supplement. The good news is the couple is comfortably in the middle class and can afford what could be some growing costs in 2025. So that's sort of our first case study, that elderly couple in their mid to late 80s into their early 90s. Our next case study deals with a female in her mid 70s and good health, but with melanoma, and she also has a clinical background. This person was unexpectedly diagnosed with melanoma. Costs of infusion therapy and more are expected to be very high in 2025. She may end up having infusions almost every month. What's more, the enrollee's MA plan was also terminated for 2025, and she had to find an alternative. Given the catastrophic expenses and multiple new doctors that will be needed, we set out and compared a successor MA PPO plan, we were unsure if all providers would be in network, to a fee-for-service Medicare supplement and Part D package. Because this person also lives in New York, she can jump back to fee-for-service and get a supplemental plan without any real premium penalties. We looked at both Plan F and G. We also looked at Part D plans because an expensive retail medication might be needed. For our scenario build, we actually chose a low to medium premium plan for Part D rather than a very high premium plan. And I'll tell you a little more about why we did that in a couple of minutes. Because dental and vision coverage would be lost, we also built in some freestanding coverage and premiums for dental and vision coverage for our Medicare sup and fee-for-service option. She does have dental and vision coverage right now in her MA plan. In the end, the enrollee decided to stay in MA and migrate to the PPO plan. While costs might be lower in fee-for-service and supplement, the difference might have been about $125 a month. The enrollee felt the MOOP in MA, having coverage under one roof, and the other supplemental benefit perks made it a good bargain for her, and she wanted to stay in MA. And with an expected good treatment outcome, her costs would go down in 2026. And again, I would note that this person had that same New York HMO plan founded by a provider, and there's great comfort in how she has been treated over the years. So that is our second use case, a mid-70s female in good health, but with an unexpected diagnosis of melanoma. With that, we'll take our first break, and then we'll come back and continue our use cases about open enrollment. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Mark Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Mark dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Mark is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Mark's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We're talking about some open enrollment use cases because I deal a lot with folks who give me a call and ask me for their advice and to help them with researching some of their open enrollment questions, especially if they have some unexpected life changes that could really change their healthcare profile. We've given you our first two use cases before the first break, and now we're going to continue on. Well, our third use case here happens to be a female in her early 70s who is in good health but has osteoporosis. Each year, I help this woman decide what standalone Part D PDP plan is best. She has Medicare fee-for-service and a strong Plan F for Medicare supplement. Her Part D needs right now are relatively small, but we do elect a medium premium plan in case her needs go up. This is a question of comfort for the enrollee. I call this case out because in the past, she was paying several hundreds and sometimes thousands of dollars a year for coverage of Prolia to treat her osteoporosis. And she was generally paying this out as part of her Part D cost sharing. But recently, she has begun receiving the drug twice a year at a freestanding ambulatory center. Her claims have been paid under Part B and her strong supplement policy. Her costs have now gone down to zero because Prolia was transferred from Part D to Part B. And so that's a great story for her that I found out when she talked to me again this year, and I explained to her what happened and to make sure she always gets her Prolia infused twice a year at the center. With that, we're going to move on to our fourth use case here. And our fourth use case is a woman in her late 80s, has moderate to poor health with about 10 medications, so her Part D plan is especially important to her. I have helped this elderly person for many, many years now. She has traditional Medicare and Medicare supplement because of where she lives part-time. Medicare Advantage coverage is just not very good in parts of rural Georgia where she lives. Thus, she needs a PDP plan to go along with her traditional Medicare and Medicare supplement. In the past, I have gone between low premium and lower benefit and high premium and high benefit plans in Part D, depending on the plan design in a given year. I chose the lowest overall outlays, so I might have had her pay more premiums out of her Social Security check for Part D and have lower cost sharing and perhaps no deductible in a given year. And in other years, I found a very low premium plan. She would pay a deductible and slightly higher cost sharing. But I always built her Part D plan from year to year based on her drug benefit, as well as what was the cheapest for her overall. With the diminution in benefits in 2025 in both MA and Part D, though, finding a plan that is very strong in Part D is becoming much more difficult. For the first time in a long time, I recommended moving her to a different Part D sponsor. Usually we always kept the same sponsor. And to change pharmacies even to a preferred pharmacy because her costs would have gone up dramatically. So this new Part D sponsor, Part D plan, and a change in pharmacies to a preferred pharmacy will save her about $500 a year compared with maintaining coverage in her current PDP sponsor, although she still would be spending a lot more money. I also told her she could get 2 of her meds at her current pharmacy to save even more by essentially splitting up where she gets her drugs. But that is perhaps a major inconvenience for the money she would save. So that's our 4th example of our use case. And now we'll move on to our 5th example here. And it's a couple that was just turning 65 and becoming Medicare eligible. A retired couple had a bit of a complex situation in terms of how they thought about what Medicare options they were going to choose. Both, again, are just turning 65. The male does not have retiree coverage in his own right, and at the time was unsure if he would receive a benefit from his spouse's plan. One complication was where the couple will land in retirement. They are in a suburban county of a large state right now with very good MA penetration, and MA plans are plentiful and strong. But areas of the country that they are thinking about retiring to have less MA penetration, and benefits are not as strong. For the male, we researched 2 scenarios because of the uncertainty on spousal coverage and where they would live. I recommended that he enroll in fee-for-service and get Medicare supplement, which was pretty affordable at his age. We ran the numbers and told him what the cost would be. I explained that if he moved to a strong MA area, he could drop fee-for-service and go to MA later. But that it was much more difficult to do the opposite in some states. The state they are in now and those they are looking at are not strong, expansive guaranteed issue states. The second scenario we looked at is when we learned more about the spouse's retiree coverage. She got her summary of benefits, and we learned that her WRAP was an MA supplemental WRAP plan, known as an EGWP. The interesting thing about this plan is that it is in essence mirroring a fee-for-service plan where percentage cost sharing is assessed on almost every service, but there is a great $1,000 medical MOOP and the standard $2,000 Part D MOOP for 25. In addition, it had both in-network, the national plans network nationwide, and out-of-network coverage. Every other Medicare provider in the nation was included. The plan also offered some supplemental benefits for vision, dental, and more. At $70 a month for the spouse that was previously employed with this employer, this was a tremendous deal for her and much better than enrolling in fee-for-service in Medicare supplement. So I strongly recommended to her that she take the MA coverage that she was offered. What's more, we did learn that her husband could enroll as well for a premium of $350 a month. In the short term, the fee-for-service and supplement scenario we researched would have been cheaper, but he would not get the dental and vision, and supplement rates would likely increase far more over time than the increases in the spousal and dependent coverage that he is now getting. For about $50 or $60 a month more, he has decided to enroll as a spouse for the all-in MA EGWP plan that his wife is also enrolling, and because it also solves the network dilemma tied to their likely move during retirement. With that, we will move to our second break and then come back to close out our last few use cases.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We've already talked about quite a few use cases, and now we're going to sum up with 3 more use cases here before we get to some observations and some advice and other observation about the healthcare system as a whole that I learned from this open enrollment season. This next use case involves a young couple that just got married with employer coverage. They're all very healthy, and there could be children on the horizon. A young couple called me with the question about what they should do in their first open enrollment season as a married couple. They work for different companies, but both companies have rather strong benefits and were somewhat generous on employee subsidies. But there was concern about what would happen if one stopped working due to pregnancy. This was easy. I recommended they both stay on their current employer coverage plan for now. The female had stronger overall benefits and could include a newborn on her coverage. If one of them stopped working, this would be a life event, which would allow a spouse or child to migrate to the other's coverage. Voila, an easy way to save money and ensure you have the ability to have everybody on the same plan in the future. And my last use case for the season is my daughter, who you've heard a little bit about on the podcast, called Kitty. And my daughter had brain surgery earlier this year, so her health is a little bit in flux, and we need to probably maintain decently strong health care for her in the United States. I've done a number of blogs on my courageous daughter choosing to have brain surgery. All turned out great for her so far. My daughter went to college for both her bachelor's and graduate degrees in the United Kingdom. She is now living there on a 2-year extended visa post her master's degree that she received recently. She is looking for full-time work in her field in the United Kingdom. She has a discrete period of time to find that work. At the same time, she is searching for work in her field in the U.S. and other countries. She has UK healthcare coverage for now. But because she had brain surgery in America and has a year's worth of expensive follow-ups coming up, I have maintained coverage in the United States for her in the exchanges. I have maintained very strong platinum exchange coverage for her because of her then brain condition, the possible need for surgery, eventually her surgery, and for very expensive medications that she needed for what was her brain condition at the time, as well as debilitating headaches derived from the brain condition, as well as a family history of migraines. Thankfully, all symptoms are done, including debilitating headaches, but some migraines could return. The severe headaches were likely both a result of the brain malformation and a family history of migraines. But those who undergo anesthesia tend to have headache relief for up to a year's period. So we're waiting to see what happens. Because she could end up back here in the United States, I always plan to continue coverage post-surgery into 2025. While follow-ups are occurring early this year when she is home, I had hoped to move her from the very expensive Platinum plan to a cheaper Silver plan. I figured it would probably be okay because the surgery is now over and she likely would not need all of the expensive medications. But in researching this, what I quickly found out was the following. Silver is still very expensive without a subsidy. She does not get a subsidy for a whole range of reasons, including the fact that Florida has not expanded Medicaid. Silver has high deductibles, and more services are being subjected to deductibles, including drugs, in the Silver benchmark plans. And Silver has very high maximum out-of-pocket costs as well. When I considered all this, I decided to keep my daughter on a Platinum plan for another year at now the huge rate of $850 per month. That compares to about $600 a month for Silver. While there is a $250 difference, the truth is that the follow-ups on a Silver plan would cost between $1,000 and $1,500 out of pocket on a Silver plan as compared with no more than a few $100s on a Platinum plan. In addition, if she does need any of her expensive medications again, they would be subject to the deductible as well as cost several $100s a month on Silver. On Platinum, they are a simple copay. Now, the fact is that while she has coverage in the United Kingdom, not all of those expensive drugs were always available to her over there. So we always wanted to have a safety net with U.S. coverage. Platinum also has a $0 deductible and a very low MOOP if I stay with it. When all is said and done, the additional $3,000 of Platinum costs for premiums was clearly worth it. We could end up spending more on the Silver plan than the Platinum plan, depending on what the future holds. And we also know we have better security with Platinum. I admit not everyone has the ability to make the decision to do this. We're very privileged to earn a salary where we can make these decisions. So my main point here really is that Silver coverage in the exchanges, for those not getting cost-sharing subsidies, has become hugely expensive, and accessing care is financially very difficult. How does someone pay even $600 a month for Silver individual coverage and then face huge deductibles, cost sharing, and very high MOOPs? It is clearly a huge problem in the exchanges. While I support them a great deal, clearly some kind of reform has to occur. With all of our use cases done, we're going to take our third break. We're going to come back for some of my advice and observations, as well as more discussion about what I think all of this tells us about the healthcare system in general. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Mark Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Mark's insights. Twice a week, Mark publishes a blog to go deep into a current issue. And of course, Mark hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Mark's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We are talking about some of my work I do with people each year during the open enrollment system and some of the use cases that I came about this year. And now we're going to just give you a little more advice and some observations about what I learned this year. On Medicare, Medicare Supplement, and Medicare Advantage, here's some of what I would advise and some of my observations. Number one, while most people cannot really switch between MA and fee-for-service/supplement, you should definitely know your state's rule on guaranteed issue, because in some cases you may be able to do it. This could be something to consider depending on projected expenses over time. Number two, if you do not know where you will settle in retirement, think about your options very closely between MA and fee-for-service. Number three, employers more and more are converting to MA egg whip wrap programs to reduce costs. Sometimes that can be a bad thing if you only have local networks. But for employers looking to craft national coverage, it can be a very good thing for people looking to travel the nation or relocate. Number four, if you are a federal retiree who has a choice of enrolling in Medicare, look at both options. It may be cheaper to be in the FEHBP retiree plan, but it also could be cheaper by converting over to Medicare. Number five, with MOOPs in MA and in the Federal Employee Benefit Program capped, some consideration should be made to both HMO and PPO options in case out-of-network coverage is needed. Sometimes the MOOP is higher if you access out-of-network coverage, but that can be very handy again if you have a life event or are traveling at certain points during the year. And last in this category, if choosing Medicare Supplement as part of fee-for-service coverage, consider your estimated cost sharing against the added monthly premiums for richer plans. A good example here is while Medicare Supplement Plan F is now cut off for newer Medicare enrollees, it is still an option for some. But oftentimes, Plan F's premium is far more than Plan G, and the only difference in coverage is the Part B deductible. Let's move on to standalone Part D advice and observations as well. Well, number one, the world of Part D is changing dramatically. With costs going up in the drug world and problems with mandatory benefits from the government, benefits are changing dramatically, especially in PDPs. Deductibles are increasingly present. Costs in various tiers are changing. Generics may or may not have low cost sharing. Non-preferred and specialty tiers have very high cost sharing. For those with catastrophic costs each year, the 2,000 cap helps. But for others, costs will increase, and choosing wisely is key. Number two, with the migration to a 2,000 cap on Part D each year beginning in 2025, it actually may be unwise to choose a very high premium plan. You might think the plan is better and has better protection. But if you are going to max out due to drug costs because you have expensive drugs anyway, a lower premium plan could be better. You also can enroll in the Part D smoothing program where you can pay cost sharing over 12 months. Number three, always consider your Part D premium against your anticipated needs. Number four, more and more Part D plans will require you to pay most or all of the standard deductible. Look at the deductible against increased premiums before you decide to pay for a higher premium plan. Number five, Part D plans are increasingly using preferred networks, which offer lower cost sharing. Look at this closely. It may be advisable to change the pharmacy at which you're getting your drug, and it could be just up the street. Next, given the use of preferred pharmacies, it is also possible to save within a PD plan by determining what costs are at different pharmacies. If you don't mind, it could be a little inconvenient, but you could save money by finding out what those costs are at each pharmacy based on your drugs. But remember, it's not for the faint at heart. Last, there are a number of drugs like Prolia for osteoporosis, as I pointed out, and other categories of drugs that could be covered under Parts A, Part B, or Part D, depending on circumstances. In most cases, the part that the drug is covered under is dictated by Medicare. But in others, there is more ambiguity, and coverage in a given part could be determined by how the drug is even administered. And what you pay can be determined by your other coverage, such as Medicare Supplement. Make sure you examine all this regardless of what kind of coverage you have. Sometimes doctors make bad decisions without regard to your cost sharing, and you can very easily work with a doctor or even with your plan to find what part a given drug, if there is ambiguity and a difference in how a drug is administered, that could save you a great deal of dollars in cost sharing. Let's move on to a couple of quick points on employer coverage. While there are protections in the Affordable Care Act as to coverage in the employer world, self-insured employers have some leeway, and coverage can be very different between employers. So in some cases, it might make more sense to take family coverage from one employer rather than splitting up the family. Also, take a look at benefits. A good example is fertility coverage. Some employers offer it and others do not. This can be the same with many other benefits. Let's move on to the exchanges for a couple of last points. While I am a huge supporter of the ACA and exchanges, premiums and cost sharing are again increasing dramatically. It's a huge problem. If you can get a premium and a cost sharing subsidy, definitely take it. Otherwise, you could be paying a great deal and still have a huge problem truly affording to access your benefits. And if you can afford it, run the numbers on the difference between lower tier exchange plans and higher ones. You could actually find out that richer plans will cost you less than less generous ones. So with my advice and my observations that came out of my use cases, I now want to give you a better feel, in my view, about what all this really means about our healthcare system in general. So I just have 5 quick points before we end the podcast. My first point, the American healthcare system is unreasonably complex and burdensome to plans, providers, and consumers. We see that in our use cases. As you can see from these open enrollment cases, it is hard to make heads or tails of the system and insurance products. I am a so-called expert, and I have to admit I was mystified sometimes by what I had to research in the time it took me. In some of the cases, I was talking to doctors and nurses who unfortunately were confused as well. The complexity not only leads to consumer confusion, but to hundreds of millions in unnecessary administrative costs, errors, abuse, and fraud. My second point, we have far too many lines of business and products and plan types within them. This is a product of an irrational system overall, but also of a lack of uniform pricing and network strategies. While I favor continuation of employer coverage as our main access point, there is no doubt we could reduce the number of coverage programs and reform networks and delivery. My third point, while we have made progress toward access to healthcare, these use cases show that by no means do we have affordable access. Whether Medicare, exchange, or employer coverage, costs are increasing and premiums, deductibles, cost sharing, and exceedingly high MOOPs serve as huge barriers to true access. We are fast becoming a nation of the underinsured if we are not already uninsured. My fourth point, it is easy to blame insurers for premium costs and plan benefit designs, but provider prices drive this. Costs in the system are out of control, and we desperately need to tackle price. And my fifth and last point, the high costs also serve as a barrier to primary care and true care management. While more preventative services are now at zero cost thanks to the ACA, too many services still require high cost sharing and are a disincentive to manage chronic conditions and stay healthy. So with that, we'll end this edition of the Healthcare Labyrinth podcast. We hope you enjoyed it, and we'll see you next time. Take care.
Thanks for joining Mark and the Healthcare Labyrinth podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth podcast.